Today we discuss Wilms Tumour, its epidemiology, staging, and treatment. So, starting with the scenario, government worldwide is brought to the first to the irregular results. Smaller states that frequency has been pale and tired. It has been more facile and less playful than temperature is 6.7, blood pressure is 100/60 of 12/40, and disparity rate is 16 per minute. Digital examination remains spontaneous bursts of non-repeatable great items in various directions. Patient also has mindfulness involving the tongue and the lips as well as generalized. Right sided, not under immobile abdominal mass is palpated and emotional status being ready and first. Sexual means anemia, and the urine is positive for elevated levels of categorically pregnant. What is the most common causes? We will come to answer this question. I hope you make an idea, make a guess with the answer. So, epidemiology of the Wilms tumor, it's an embryonic tumor on the immature human post renal malignancy in children. Incidence is per in children. 6 to 7% of all childhood cancer, more than 80% diagnosed before age 5, and the median age is 3.5 years. It's equally common in both sexes, with some geographical variations, and more common in positions as compared to patients, and the bilateral limb is diagnosed in 5 to 10% of cases. The genetics of the limb tumor, either it can be familiar or it can be sporadic. In the familiar, the most common gene involved are WT1 and the WT2. And in sporadic, there are 10% that are associated with some syndromes, and there are some other genes that are several genes that are involved that we discuss in the coming slides. The sporadic ones. So the WT1 and the WT2 gene deletions are the two most frequent genetic abnormalities in Wilms. WT1 was first identified gene in Wilms tumor and is responsible for the development of GU system. It's a tumor suppressor gene located on short arm of chromosome 11. It is deleted in Weger and Dennis Preston. We'll discuss both of them in the coming slides. And the second gene is WT2. This gene is located in chromosome short arm of chromosome 11, and it is found in Beckwith-Whitman syndrome. The mutations of P53 occur in 5% of the Wilms tumor and have been found in 75% of patients with anaplastic histology. Anaplastic histology carries the poor prognosis and is associated with the mutation of P53. In addition to that, there is loss of heterozygosity and short arm of chromosome, and it is common among 3 to 4 times higher among mixed and diffuse anaplastic tumors. Both of them carry poor prognosis compared to favorable histology tumors. We will get to know what kind of what is favorable histology and what are unfavorable histology. So the associated syndromes are Weger syndrome. These are the most common syndrome. Weger syndrome and stress syndrome, Beckwith syndrome, Wellman syndrome. It is necessary to have an idea about these syndromes so that we can pick up the additional findings in the clinical examination as well, while examining a patient with full history. The Weger syndrome, it is associated with the deletion of WT1, and the associated pathologies are really obviously Wilms tumor and iridia, that is loss of the iris as shown in the picture. And GU malformations include hyperspadias in the undescended testes and the mental retardation. So the four features of failure and iridia, GU malformations, mental retardation, and Wilms tumor. The next syndrome is Dennis-Dress syndrome. It is also associated with the loss of WT1, and it is associated with diffuse mesenteric cellular ulcers leading to protein media necrotic syndrome and multiple PSI. and pseudohermaphroditia. And in pseudohermaphroditism, the mates are consistent with the chromosomal sex, but the patient had external genitalia of opposite sex. And the third thing is Wilms Tumour. So the three features of demonstration are the genital circulations, pseudohermaphroditism, and the Wilms Tumour associated with the beauty, this time, the previous one. And the next is backward radiance. It is associated with initial WT2, and it has features of macroplasia and gigantism at the birth, visual memory. It could be spleen, liver, high birth weight, controversy, Wilms tumor, and hepatic tumor. 5% cases. These are the pathology associated with the backward radiance. And the last one is pyramidal syndrome. Uh, its features include microsomia, islets and hyperplasia of pancreas, and the leader anatomies in the analytical phase. These are the symptoms and associated with the. Coming towards the clinical presentation, most common feature is abdominal mass. The most common feature that varies huge hematuria in hematuria in 20% of the cases, and it's limiting that is 10% cases, 5% cases. Examining the patient of Wilms tumor includes the core examination, starting from the physical examination, the limbs, as well as the chest, abdomen, as well as of the limbs, carry out some associated symptoms as well. And in diagnostic work, we start with an identification presenting. First, we start with an ultrasound, and if it is showing a solid mass suspicious of Wilms tumor, then we head towards the typhoid CT scan. And the images shown in the picture are bilateral Wilms tumor. The sign, the arrows pointing towards the cross line. It is basically the tumor displaces the nerve brain line. Okay. And the shape the cross line where the chest is abdomen in the pelvis is necessary for the stapling of the tumor. The chest for any metastasis. So the management changes if they are in the chest or the liver, then it's the sides of the metastasis. Treatment. And then we go for the treatment. And we will discuss later on either we should go next pathology application before surgery or not. And then MRI more sensitive to look for the extension of the shoulders in the RBC. And then the actual probe scan in very selected places where we have been further expensive. Where we have been by the stage of the tumor. So basically, for the management of the Wilms tumor, there are two management plans. One is children oncology group, and the other is SIRE. SIRE is the National Society of Pediatric Oncology. All guidelines are followed in North America, and while the SIRE guidelines are followed in Europe and most of Asia. So they slightly differ in the management as well as the staging. Most of uh, the points are similar in staging, except in stage 3, the board says even if you are taking the biopsy, if taking the needle biopsy, they will label it as stage 3. While in SIRO, they don't, they label wedge or open biopsy as stage 3. And they say that there is necessity to take the biopsy. We in pediatric department follow SIRO guidelines, so we biopsy the for SIRO. So the stage 1 is tumor is limited to the healing and dissected in core guidelines. While it is similar in SIRO, the tumor is stage. And in stage 2, the tumor is not damaging to the brain. It is involving the structures like the human fat, but it is completely disintegrated, where the margins are not. Then we label it as stage 2. While in stage three, if you have left some of the tumor or the margins are affected, then we usually have stage three. And stage four, there is metastasis or spread beyond the abdomen and chest, then we usually have stage zero. And if there are targets of tumors, then we usually have stage. So, as I said, in child protocol, we take the needle biopsy before starting deciding the patient. So the benefit of the biopsy is that we can do biological methods. And according to Shire guidelines, the two-needle biopsy does not upstage the disease as well. And the complications associated with two-needle biopsy are very, very great. So we get an idea in biopsy what is the percentage of different components. Epithelial stroma and plastic. We got three major components in the Wilms tumor, and we get an idea of the percentage, and then according to that, we start pre-operative according to Shire. And the last, the presence or absence of anesthesia that decides that plays a major role in deciding the prognosis of the host. So on biopsy, we look for the percentage which is if a tumor has 20% complete diagnosis, it carries a very good response, it's a low rate. And if it is of aggressive type, or it is of mixed type or stromal type, then it's an intermediate risk tumor. And if it has a blastoid component or there is presence of anesthesia, that means it is a high risk. So biopsy gives an idea more about how the tumor is. So as I said, there are two management plans, the cord and the sire. The children oncology group says that we should go through upfront surgery without preoperative chemotherapy. We should go for upfront surgery, and after the surgery, we go for adjuvant chemotherapy, where radiation will be expected the stage of disease. While they say that pre or chemo is given only in selected cases. We look at the SIR, which follow other institute as well. It says that upfront chemotherapy followed by surgery, biopsy, chemotherapy, and then we do surgery. And then further chemo, adjuvant chemo or radiation stage after this. They are equally effective. The prognosis, overall survival, they both vary greater than 90% in low stage and greater than 80% in high stage. There are different benefits that have been produced and very good. So the advantage of the core guidelines is that we get an accurate estimate. We can decide that the benign versus malignant disease. We get an accurate stage in because we go for upfront surgery, so it is not affected by the tumor is not affected by the tumor. We get the original information, and we avoid giving therapy to benign or advantages are there is increased risk of surgical complications. There are chances of tumor spreadage. There is failure to sample slightly. While in SIO, as we have given pre or chemotherapy, there are fewer surgical complications. There is no incidence of tumor rupture as we can downgrade the disease. We can assess the tumor response. There is a role of nephrostomy surgery as well. We have downgraded the tumor, but has got down, then we can go for nephrostomy surgery as well. But the disadvantages are there is modification of tumor histology, there is loss of stable information. We can give chemotherapy in benign disease, or we can give chemotherapy for different inside. So the management involves multiple teams, including surgical oncologist, radiologist, pathologist, oncologist. All the teams are involved in deciding its necessary to discuss every case in that board meeting and then decide accordingly the different approach to different needs. So in the management, the pre-operative chemotherapy, the broad guidelines recommend surgery, as we said, the initial therapy before chemotherapy. But there are some cases where these are the selective cases in which we should give the chemotherapy in broad guidelines as well. And the indications of pre-op chemotherapy in broad guidelines are the tumor is inoperable and it's solitary kidney, or there is synchronous bilateral tumors, or the tumor is involved in the inferior vena cava, or it is extending above the level of the veins. Tumor involving small structures, whereby removing the kidney tumor requires the removal of the other organs such as pancreas or colon, and with extensive pulmonary metastasis. In these cases, we can go for preoperative chemotherapy. This is what the path and the common events for chemotherapy are toxicity with the dectinomycin for the increased. And if there is anaplastic histology, then we need to give oxygenation in every patient. The PSYOP guidelines recommend preoperative chemotherapy for all patients after diagnosis, after doing the technical diagnosis. PSYOP recommends preoperative chemotherapy to every case for patients with unilateral localized tumor. The recommended treatment is 4 weeks with two drugs, that is vincristine and the dexamethasone bi-weekly. For patients with bilateral tumors, this is what we follow in our institute. For patients with bilateral tumors, vincristine, dexamethasone for more than 9 to 12 weeks is recommended, and the hydroxyurea is on for reinfection. For patients with metastasis, a regime of 6 weeks that includes vincristine, dexamethasone, and oxygenation. So the surgical considerations, the more important of us are extent of the tumor. Surgeon must know before jumping into the surgery what is the extent of the tumor, its location within the kidney, and its relation with the central vessels, the IVC, liver, diaphragm, pancreas, spleen, and every glands in the body, and enlarged intraabdominal, specifically paralytic lymph nodes, because we need to take out these nodes for staging and look for the tumors in the liver field and its extension into the IVC for planning for the surgery. Chemical approach is the minimal invasive and the open surgical approach. The minimal invasive approach grounds for becoming in the open surgery. So this, in open surgery, we always go through the transperineal NCN because we cannot go through the lumbar NCN because the X-ray is not adequate. We cannot take out the lymph nodes. So always go through the transperineal. And exploration of the abdomen for look for the liver metastasis and to look for the peritoneal seeding. Controlated renal exploration is not mandatory in every case, and laparoscopic surgeries are optional in selected cases. Radical nephrectomy assess the steps are the early dilution of the vessels at the first pregnancy, and then nephrectomy with the ureter divided as distally as possible. Remove tumor with the surrounding adipose capsule, plus gyrothalacia. The renal gland can be left in situ if safe resection margins are present, and the vein and IVC should be palpated for extension. Tumor extension into the renal vein and proximate IVC can be removed and blocked with the lymph node dissection and the number of lymph nodes that are required are 7 local lymph nodes. This is the number that is required for the accurate study. And hilar and para-aortic lymph nodes should be sampled even if they are not suspicious. Involved or suspicious lymph nodes definitely should be excised, and the radical lymph node dissection is not recommended. So if you have taken out the 7 lymph nodes, they are adequate for the study. Post neoadjuvant chemotherapy, the necrotic lymph node should be considered as well. So nephron sparing surgery, the SIO, double German contraindications of nephron sparing surgery, in which cases you should not go for the nephron sparing surgery. The number one is if the tumor is infiltrating into the extrarenal structures, there is the abdominal metastasis or lymph nodes, the thrombus in the renal vein or the IVC, and if the tumor is not involving more than one third of the kidney. The disease is multifocal, or if it is centrally located, if there is involvement of dialysis, and there is presence of anaphylaxis and reserve your biopsy. So the recommendations for the nephrostomy surgery are if the tumor is bilateral and if the clinic is solitary and very patient with partial kidney, if the patient is having associated damage slash or fracture syndrome, and if there is associated renal insufficiency. In these cases, we should look for nephrostomy surgery, we should refer. So after surgery, we need to give the patient adjuvant chemotherapy or radiation therapy if there are metastases in the chest. So adjuvant chemotherapy, what are the core guidelines? It recommends post-operative chemotherapy routinely used in all patients with Wilms tumor, except those that have like very low risk, that have high component of necrosis. Younger than 2 years at diagnosis with stage 1, favorable tumor histology, and if the tumor weight less than 550 gram, and there are confirmed negative lymph nodes. This case, we can examine the adjuvant chemotherapy. Otherwise, God recommends post-operative chemotherapy in all patients. While in the SIOD guidelines, it recommends post-op chemotherapy also in all patients with Wilms tumor, except those one with stage 1 very low risk. So there are some prognostic factors that predict the prognosis of the tumor, and these are the loss of fibrosing at the chromosome, short arm of chromosome 9, and the long arm of chromosome 16. There are chances of increased relapse and death, and an increased number of expression at chromosome 12 and telomerase expression level. This suggests unfavorable prognostic features in the DNA content. The DNA content, DNA index is greater than 1.5. That is strongly associated with anaplasia, range system, poor outcomes. Then some of the cytokines that are IGF2, PWS, EGF2, and above they are lung metastasis. They suggest a patient with a lung mets. And the age, if the patient has increasing age, there are increased chances of recurrence. So bilateral Wilms tumor. This is a case of bilateral Wilms tumor, where the arterial phase of the CT can, special hospital and and there are bilateral exams we can appreciate in both the buildings. And this patient uh, had received preoperative chemotherapy followed by after biopsy he received chemotherapy. And the bilateral lymphoma is challenging because we should really we can say, and also we need to take on the clear section margins. So synchronous bilateral tumors are 5% of the children in 5% of the children, and we should not they should not undergo initial radical nephrectomy. And the goal of preoperative chemotherapy is tumor shrinkage and renal stability. The kidney with a lower tumor burden should be addressed first. If tumor fails to respond, bilateral nephrectomies and dialysis are required. And for renal transplantation, negative renal tissue should be removed to prevent tumor recurrence after transplantation. So the goal is preoperative chemotherapy till we achieve the tumor reduction. Food eggs initially, and if there is poor response, we have doxorubicin as well with that drug. Surgery individualized and each kidney according to stage. Partial nephrectomy on each side, or maybe total nephrectomy on one side, and partial on the other side. And really bilateral. So the follow-up of the Williams tumor, if we have done the surgery and then the adjuvant chemotherapy as well. So It requires a long time for the application of instrument for the telescope requirements. And in follow-up, we look for the general well-being and the growth of the pit, the blood pressure, in every visit, the ultrasound abdomen, the X-ray of the chest. We look for any nodule or any deeper metastasis. And once a year, serum creatinine will be shown for those patients who have normal renal function. And 3 monthly creatinine in those patients who have renal dysfunction. And once a year, we will be uh, 3 monthly follow-up for the first 2 years, 4 monthly follow-up for the first 6 monthly follow-up for the 50, and a yearly follow-up for 10 to 14 years. In case of relapse, will be based on relapse, intersection, CT cap, or stage, and the biopsy of the relapse in the chemotherapy versus surgery. Coming towards the study, like we started studied at the start of the presentation. So CN enablement worldwide is going to have faced irregular jerky movements as well as the respective means less the pale and tired. He has been more physical and less playful than usual. Temperature is 36.7, blood pressure is by 60, pulse is 140 per minute, especially 16 per minute. Basically, evolution reveals spontaneous flush of the norm between conjugate eye movements in various directions. The patient also has myoclonus moving the joint balance, as well as generalized. A right side is no tender, immobile, abdominal mass is palpated. There is no cytopenia again, and the bowel seems on that CBC reveals anemia and the good news positive for elevated levels of critical amines. Later on the right, which of the following is most likely to be? We can get an idea from this statement that the Wilms Tumour is less likely, and the final side of the scenario is there are other dimensions of the Wilms Tumour as well, which that we need to keep in mind. Not every case presented with a terminal mass of Wilms. So anyone can suggest because the diagnosis is right.
हम बताएगा ये डिफरेंशियल्स बताएं डिफरेंशियल्स में क्या क्या डायग्नोसिस
Pheochromocytoma, neuroblastoma,
ये तो कह रहे हैं इसकी वजह है
elevated levels of catecholamine.
ये इधर डिफरेंशियल एग्जाम में आपको सिनेरियो मिलेगा डिफरेंशियल पूछ ही लेंगे कुछ तो बताएंगे ना तो बहुत सारे लिस्ट है डिफरेंशियल्स पे तो जस्टिफाई योरसेल्फ ये हो सकता है
Second, neuroblastoma also.
क्यों कोई वजह एनी पॉइंट फेवरिंग प्लाज्मा
Symptoms, scenario में जो symptoms हैं,
many regular jerky movements tired pale कहते हैं और बताएं जिस टाइप की डिफरेंशियल्स में सब आ सकता है एनी पॉसिबिलिटी
तो कौन लोग कुछ पूछना चाह रहे हैं?
मेरा कैसे था इस न्यूरोब्लास्टोम
Yes, said right, most likely diagnosis. It's very obvious from the physical examination and the symptoms of the patient. It's neuroblast. The fear comes from the second is less likely to research and in Williams tumor, it's less likely that the patient will have because of the elevated level of critical and so the symptoms establish myoclonus syndrome in the joint Williams as well as generalized symptoms suggest that the patient have neuroplasm. Right diagnosis neuroplasm. Regarding the Wilms tumor.
आपने जो स्टेजिंग बताई है, स्टेज टू जैसे बताया कि कम्प्लीटली अगर मार्जिन सेक्टेड हो तो स्टेज टू होगा, और अगर पॉजिटिव मार्जिन तो ये स्टेजिंग स्टेजिंग जो है ये प्री सर्जरी प्री ऑप या उस पे फ्रोजन सेक्शन.
Pain, sour, simply out and therapy. Through the biopsy that we have give immediately of chemotherapy, we can go for the surgery. While in children oncology group that is followed or guidelines instead of followed North America. they go for upfront staging. So if you are looking for the staging according to core guidelines, they are for the tumor live tumor that has not received any chemotherapy, right? So stage one is tumor is limited to breathing and you have completely taken it out. Stage two is if you have the tumor that is involved in the genetic structures, but you have taken it out completely safely and the margins are linked. That is stage two. And in stage three, the core guidelines suggest that even if you have taken a biopsy, needle biopsy, through the biopsy of the tumor, that means the tumor has spillage. They label it as stage three. While in child guidelines, they say that where you open biopsy before you get the chemotherapy in stage three, and they don't consider through the biopsy the upstage that it is. So involved with this staging according to the now that we have taken. Islands are is based on the pathological throughput. After the chemotherapy, and then you are done with the surgery. The specimen you take out, and this basically decide the stage in the side.
because you give a pre-op chemo and the disease will downstage and then you do surgery and you may not be able to find any tumor in the background then perhaps. So this is what happens in
Uh, and maybe the tumor is completely like the worst due to the therapeutic chemotherapy. So you do not get accurate histology. That's such that while you form, you get accurate histology.